Thank you, everyone, for coming to our presentation. I know the title looks a bit of a mouthful, but we hope that we're going to be giving you a lot of information as we talk about this paradigm that we're offering you. My name is Michelle Osborne, and I'll get it started. I'll have each of the folks just identify themselves as they step up in turn. Let's see if I've got this right. The first thing that I really want to do is make sure that we do understand that we are on unceded land of the Ramaytush Ohlone people who have made San Francisco Bay Area their home for centuries and still do. I would also like you all to think about the ancestors who are the guardians, caretakers, and stewards of the lands that you live on and have traveled from to be here. Please keep in mind that we're trying to describe relationships that we have with each other and the relationships between power and identity and race and gender. And the categories we use can sometimes be imprecise, as we know they are constantly evolving. We're trying to be respectful of that, and we hope that you will work with us and also educate us as need be. Thank you. Nora, would you like to take the next?
Thank you. Thank you, Michelle. I am Nora Karena. My pronouns are she and her. I also want you to know that I identify as a white, cisgendered, femme-presenting queer woman who is also a previously homeless survivor. And it is my great joy to be in this room with you all, because it is from you all that I first learned about these concepts. And in doing this work, to end sexual violence and to end gender-based violence and intimate partner violence has been how I have learned about racism and social justice and inclusivity and the work that we do. So it feels really wonderful to be with you all. I'm going to just take a moment to land on the community agreements. And I just want to acknowledge, since Corbin is in the room, that Corbin is with an organization called Chickatelli and Associates, who does the training and technical assistance for New York State RPE. And we love the community agreement format that he uses, and so we are borrowing it for today. Thank you, Corbin. But these are where we're going to start with our community agreements. We ask that you agree to actively participate, to honor intent but own our impact, because our intent very often is not always matched by our impact, that we come with open hearts and with open minds, that we share the space with each other. This is a structured space, but we still want to make room for sharing. That together we know a lot, right? So let's pull from you all are the experts here. You know, we're just the ones who are trying to synthesize what we're learning with you all and sharing it and reflecting it back to you. And our entire project has been about reflecting back the expertise that we are finding in the work. Of course, confidentiality. In this space, we're being recorded, so the flip side of that is be careful what you say and share, right? Let's share our own stories and speak for ourselves. Assume good intentions, practice self-care, this tender stuff to talk about. And so let's take care of ourselves, but also let's take care of one another. And identify people as they ask to be identified. And also, what I would like is if anyone would like to share, and we can send a mic around to help with this, if there is I'd like you to think about what agreement is most important to you, and if there's something you'd like to say about that, that would be lovely. But what's really important is, are there any other additional agreements that you would ask for in this space, or if you would ask for something here to be restated in a different way? And we'll just take a quick moment to do that. Did I see someone raise a hand?
It's okay. It's okay. One of the ones that I like to use is to recognize the empty chair. And the people who cannot be here and share their voices with us today.
Would someone like to do the writing for me here? Is there anything else anybody would like to add before are we good? So can I just, if you agree, would you just be willing to raise your hand? Oh, thank you so much. Thank you. Okay, so to the next one. Real quick, this is our agenda for the day. We've got a lot to cover, but we're going to introduce ourselves to you and orient you to the session, and then we're going to quickly talk about very briefly about some of the common challenges that we do this work within. We're going to take a minute and hear from Bernadette, who's going to describe the New York RPE program, and it's so lovely to see so many of you from RPE. I'm sorry. Thank you. Oh, okay. Thank you, Jan. It's good to see so many of you from RPE, but we're going to take a minute and talk about that. And then we're going to describe the RFP that we responded to. And then we're going to take you through our work, our philosophy, the framework we used, the methodology we used. And we're not going to give, because we're still writing the report, we're not going to give the full down and dirty. That'll be available from New York when it's complete. But we're going to give you an overview of the basic considerations that we're coming up with as a result of our research. Also, you should know that you have workbooks. The workbooks are basically this slideshow, but there's room for notes. And it'd be really great if you want to keep track of the notes, because the activities that we're going to do are going to be on the pages. So for the first two activities that we're going to do, we're just going to have you do a pair share with each other. Or with someone near you, and then write down your notes, because we've got so little time. And then at the end, in the final activity, we'll do a share out of the notes that you've taken that you want to share, and kind of the cumulative takeaways that you're coming out of the work with, or your cumulative response to what we're doing. Okay? Just go here. So this is us. We are Michelle M. Osborne J.D. and Associates, my two friends. It is my great joy to work with Michelle Osborne and Toni Belcher, and they will introduce themselves to you. And then today we are joined also by Bernadette Dolen, who is the director of the New York State Sexual Violence Prevention Unit. Very grateful that they were willing to collaborate with us on this presentation. In this session, we're going to talk about a philosophy to support a practical, actionable, anti-racist framework and the methodologies that we use to identify and address racism, specifically in health equities and primary sexual assault prevention. And that's going to be the theme you're going to hear over and over again: anti-racism, health equity, and primary health prevention. And you'll hear more about that. We hope it's interactive, we hope it's collective, and we hope it comes to some action planning. I'm just going to move forward and hand it over to Michelle, because I think I've taken too much time.
Thank you. So as Michelle Osborne, I just wanted to say very quickly that when Toni Porter was talking about were you around in 1994 in VAWA and Stand Up, Nora and I stood up, and we were thinking about how many years before 1994 we'd been in this movement. So I have done this work for a while, and I do want to say that what you're seeing on the screen right now, our common challenges, are something that all of us in doing this work have experienced at some time. Look at funding. You know how funding is not only inconsistent, you don't know when it's coming, you don't know when the NOFO is going to be released, you don't know how much money you're going to get. Is it going to be $500 more than last year or $5,000 less than last year? You never quite know what's going on. What about staffing? You've got that great ability to attract talent, people who have passion and want to do this work, but can you keep them because there are all these other issues? Low salaries, what about those benefits? What about the ability to train effectively, et cetera? And then there's process, the process of your organization, where it could be understaffed, probably because of some of the staffing issues up above, their administrative burdens. Remember that we've got to do this work, but we are not going to get any additional money for it, unfunded mandates of work that you've got to do, getting added on, actionable evaluation. But you're not really taught how to do evaluations, but you got to do evaluations or else. And what about the inertia of the status quo? How do we get innovative and creative when we have all these these other issues getting in our way. And then we have to look at the trends that are happening, and we don't want the trends to become add-ons. We don't want them to become icing on the cake or gravy. We want them to become the core of what we do. But how can we keep up? Do we have the capacity to do more heightened racism, awareness, understanding, implementation of anti-racist and anti-misogyny issues in our associations? How can we stop always being reactive and responding in a crisis mode and getting reflective and having preventative modes? And what about emerging strategies toward community-based leadership? We talk about community-based leadership. Are we doing it? So these are the common challenges that everyone in this room has faced in one form or another before. And then because we want community-based programming, we want to best serve our communities, how do we do that with our challenges? And how do we develop easier to implement evidence-based, evidence-informed, evidence-sustainable practices to measure the good work that we're doing so that not only we know that we're doing it, but the community understands. And we're doing that balancing act. This picture actually makes me very nervous because I'm afraid of heights. But I'm also afraid of when we have to do this work with very little of the funding that we really need. How do we do that? And then here's our latest challenge. With the Dobbs decision and the Harvard UNC decision from our Supreme Court, we now know that something else that we've got to deal with is how do we continue to do this work when it's under attack? The work of making sure that we are giving great services that are culturally what our communities need, and with the recognition of the history and legacy of racism and misogyny that goes before us. So we have organizations that we're beginning to hear from in certain states that are afraid to talk about these issues as a part of their work anymore, or to continue to advance these issues. I would just encourage all of us to remember that we're still on cutting edge work. Doing this work is still cutting edge. You know, there's not a lot of people out in society saying, we want you to do this work with no fear. So we're already doing the work. Let's continue to do the work and not let these latest political machinations scare us. I give you one example. Look at what the United States military is doing because it needs a diverse workforce. How is it continuing to deal with these issues despite what we've been hearing? So just some thoughts about who do we look to? Well, let's look at ourselves, but also look at others doing the work. Oh, I'm going to give this over now to Bernadette to talk about your program.
I think I have a mic, yes. Hi, everyone. My name is Bernadette Dolen. My pronouns are she, her, and I am the director of the Sexual Violence Prevention Unit at the New York State Department of Health. So for my portion of the presentation today, I'm just going to give you a little bit more context about New York State, go over just a couple of facts about New York State, and then talk about our RPE program, specifically in New York State, and how we came to contract with MMO. Okay, so there are 20 million people, about 20 million people residing in New York State. A little less than half of residents are concentrated in the New York City area. We are a very large state. We are 6% of the U.S. population and the fourth largest state in the country. New York is a very diverse state. About 30% of households speak a language other than English at home. And the percentage of non-white residents is on the increase in New York State. Okay, so New York State is not just New York City, despite what a lot of people may think. New York State has really vast rural areas. We have mountain ranges, and we have hundreds of other cities and towns throughout the state. We know that all throughout New York State, where you live is largely dependent on your health inequities, health equity, health disparities, all the things. Okay, New York State is also very economically diverse. We have some very wealthy, some of the wealthiest people in the world, in fact, who live in New York State. And then we also are experiencing a lot of poverty in New York State and a lot of homelessness and a lot of instability in terms of housing. So this map right here represents the red are counties that are currently losing people. Their population is on the decline. And, you know, what we often say is that we know that New Yorkers are struggling to raise their families in the communities where they grew up. Okay, so going beyond the county level, this map is really interesting because it really shows you from neighborhood to neighborhood the difference in number of disparities. And really, like, what's more important about this map for us is it really tells us the need to go deep in communities, to focus our work on the neighborhood level, and to not try to, within our work, to serve an entire county. You know, we know that health equity is at the neighborhood level, and your health inequities vary from neighborhood to neighborhood in every county in the state. Okay, so of course, I cannot show you that same map for sexual violence. We just don't have the data. But we all know in this room that anyone can experience sexual violence and that people are disproportionately impacted by sexual violence. And a lot of the disparities in sexual violence are related to where you live, housing instability, and the social determinants of health. So one last thing I want to say about this, you know, we don't have the data. So we are thinking in New York really critically for our RPE program, what data do we have and how can we relate it and tell the story of sexual violence, at least at the county level for now. And I'll get back to that later on in the presentation to describe that a little bit more. Okay, so about the RPE program in New York State, the RPE program is funded through the New York State Department of Health. It's in the Sexual Violence Prevention Unit. Our unit also has two other programs. We have the Rape Crisis Program and the Sexual Assault Forensic Examiners Program. So the RPE program is made up of 6 regional centers for sexual violence prevention. The regions are in the different colors on the map, and there's one lead agency and each regional center, and then they subcontract out to other organizations to partner within their region and provide RPE services or programming in 17 counties. This program has essentially been in effect for 10 years. And it was originally, those 17 counties were originally picked based on DCJS reported or law enforcement reported forcible rapes. So they were at the time, the 17 counties that had the highest number of forcible rapes. And we also have a TTA provider. Okay, so there are 4 initiatives in New York State that the RPE programs are typically implementing at least one of these initiatives. There's the Healthy Schools, Healthy Sports, Healthy Neighborhoods, and Healthy Nightlife initiative. The priority population depends largely on what initiative you're implementing, but we generally have a very broad priority population passed down from the CDC of young people 8 to 24 years old and adults of influence. Okay, so within each one of those initiatives, there's a curriculum. So there's some form of individual level programming being provided to the communities that we're serving. And then the regional centers are working within those communities to collaborate and think about ways to impact policy, environment, partnership, and trying just really doing our best to implement 50% at the community level of the social ecological model. Okay, so that is where we are. And as I mentioned, that essentially that structure, there's been variations and changes along the way, has been in effect for 10 years. And so over the last year and a half, we've had a lot of conversations with our contractors, with our TTA provider, and with people in general who are working with our programming to just ask and have conversations around what do you need from us so that we can do better health equity work? Where do we go from here? So these are some of the things that we've been having conversations about. What's our priority population? How do we get more specific? How do we ensure that our program is equitable? How do we make sure that our components and requirements are easy to implement and or make sense for the funding level that we're providing? Who are our community partners? And, more importantly than anything, how are we measuring it in a way that programs can match and make sense to them and doesn't get in the way of their critical work? Okay, so, I guess I'll say thankfully, the CDC released the supplemental funding last year in 2020 on a health equity capacity assessment. I know many of you in this room got that same email, right? And so the first thing that we did at that time was ask ourselves, what is a health equity capacity assessment? And just really pretty much stopped everything else we were doing to try to figure out what that is it important to us, and, how and who can help us get there. So, so we decided to apply. We applied to the CDC for the supplemental funds. Thankfully, our state was one of the states that was lucky enough to have enough funding to really be able to do this work with a very short timeline. We were awarded the funding and had to release a competitive request for proposals in order to select a consultant. So that all takes time, although I think we did it in absolute record timing. It was definitely the fastest one I've ever been a part of. So we wrote the RFP, we got it approved, we put it out to the world. We scored applicants and awarded MMO, I think by September. And then we're not able to, it takes time, we all know. We weren't able to get a contract with them in place until I think mid or end of November. So we only had 2 months to really get to know each other, to think about what we were going to do, and to get the work started. And then we had to pause and wait for the funding to come through for the following year. So I won't get too technical about it, but we weren't able to continue the work with them until May. So we've had a very strange timeline with a lot of interruptions, but we've achieved a lot in that time. So this is where we are right now. We've had the 2 grant cycles from the CDC that I really described as our current programming. Right now, we're working with MMO still to complete the health equity capacity assessment and think about the recommendations and then, implement them in the next 5-year grant cycle. So really excited about that. And I think that's it for me. That's you. All right. There you go.
Good morning. My name's Toni Belcher. My pronouns are she, her. And what you heard, Bernadette, and what you heard from my other compatriots here is just a description of what's going on. Each of you have a view of what's going on in your programs, and it may not be exactly like this. What we're getting ready to describe to you, though, is something that you could consider in the right size that could help you as you're trying to make the assessment of how are you handling health equity in the work that you're doing. Many times, and my compatriots know this, I like to simplify things down into, people say, what is health equity? In my view, in its most simplest form, it is how you go about doing things. What are the considerations as you go about doing the good work that you're doing right now?
So for us as consultants working with Bernadette, we use these tools. These aren't unique tools, but sometimes it's about the classic tools and how you use them. We chose to do an introductory video that she could send out to her team and related partners so that they could get to know us. It's a big, vast network, kind of hard to talk to everybody. So that was the tool that we used. We did use a survey, a very simple survey tool with questions that were crafted as we got to know Bernadette and her teams. And it was crafted specifically. So survey, not unique, but how we did the survey, the questions we asked in the survey were unique. We did one-on-one interviews to do what I love to call color commentary, right? You can only get so much out of a survey. Oftentimes, one-on-ones help you really understand the nuances and do those follow-up questions. And then really importantly is that document and data review. Many organizations like Bernadette's are very, very complex. There's a lot of moving pieces. Some of your organizations might be less complex, but taking a look at your documentation, what you do, how you do it is very important as context as you try and do this work. And then training. We know that having common language in any of these kinds of social efforts is very important. There's many ways to kind of say the same thing, but the common language, especially because time and money is short, is very important. So you're not talking past one another, you're talking with each other. And so training is something that we added. So those are the major components for the proposal that we sent to Bernadette. And we are very happy that she chose us. So with all that as context, realizing that each of you have situations that are similar to Bernadette, some that are different, what we want you to do is look to the person to your right or to your back, or move over to that person, but get a pair share as quickly as you can. Use your workbooks. We really encourage you to use your workbooks. Yeah, stretch a little bit and get on over there. And what we would like you to do, hold on guys, just want to make sure everybody has the same information. We want you to share your challenges that your organization faces very, very quickly. We have about 5 minutes for this. We want you to use your workbook to write down 2 to 3 of those challenges. Then we want you to save that list, and you can keep writing on it as we continue with our session, because we're going to use that work in just a little bit. So you got 5 minutes starting now. So we got the question of, so what kind of challenges? And it's a really important question, because all the challenges is what we're talking about, because health equity is the how. So if you have a list of 10 challenges, it's not number 11. It's part of the 10. So what I want you to do, thank you for this 5-minute breakout. I want you to continue to think about that as we go on with our session. You have your workbooks. Keep writing, keep thinking, and then you'll have another opportunity to sort of address that. I'd like to turn this over now to Michelle.
Thank you, everyone, for engaging with your neighbors and talking about your challenges together. And that's the way we're going to continue to do this work and be successful, collaborating even with people we don't know because we have this work in common. So what we want to do is tell you some of the philosophy of this team and our belief system and how that brings us forward to work with health equity. I want to say that my pronouns are she, her. I also want to say that once upon a time I was a Brooklyn girl, and there's still a lot of Brooklyn in me. So again, thank you, New York, for showing up so well in this room, and for everyone else for engaging with us in that way. You know, we have this poem that we really like by Antonio Machado, and I unfortunately do not speak Spanish, so I'm not going to attempt that. But what this says to us, it's a reminder that we are creating the path that we need. We are creating the moment that we need together. So walker, there is no road. The road is made by walking. If you think that this health equity work or the end of racism or misogyny is going to be handed to you, we've got to continue to do this work. But we've got to have philosophy, we've got to have a framework, we've got to have a methodology for doing this work as successfully as we can. So this is some of what our group works with. Under DEI, which we all know stands for diversity, equity, and inclusion, I sometimes say DREI, diversity, racial equity, and inclusion, we have some of what we call the 8 Ps plus the word technology. So people, perception, philosophy, politics, policy, procedure, process, priority. We are always working with that. You all are always working with that in the work that you do. And you're always making decisions about how you leverage that for and against the work that you do. So that's one of the things we're always thinking about, and I'll come to the 8 Ps plus technology leverage in just a moment. But I also want you to know that we believe that when you have best practices, whether they're organizational or operational, they're best practices. They can be adapted to the work that you do. So we have sometimes looked outside of our field for best work, best practices. So sometimes it looks like, oh, that sounds kind of corporate, but can we adapt it to make what we need to do work? Oh, that sounds kind of governmental as a best practice, but can we adapt it to make what we are doing work even better? So don't ignore best practice because it's outside of the arena. Look at it as, can it be adapted to do what I need it to do? We also believe that that helps support organizations and accomplishing the mission. You know, in the world that we're in, where we continue to talk about racism and misogyny, how do we get here? How do we get out of it? Another thing that we want to be really clear about is that if we are focusing on bad policies and ideas, if we're focusing on systems and structures, then we're not focusing on bad people, individuals, and losing sight of what's really going on, which is the systemic and structural racism and misogyny that we are working against. So we believe that it's more productive to be inclusive and to understand that if we're working against bad structure, bad policy, there are many, many people we can include in doing the work. And we believe that Professor Ibram X. Kendi of Boston University, he's the founder of the Center for Anti-Racist Research. He's the author of books like Stamped from the Beginning, History of Racist Ideology in the United States, and also How to Be Anti-Racist. We really believe in what he offers us for doing this work. So let's look at another way in which we think about how we do this work. What is a methodology or a framework that we can use? So I mentioned those 8 Ps earlier: people, perception, philosophy, politics, policy, procedure, process, priority, and also technology. And what we are saying is that to get to health equity from where we are with health and equity, we have to be able to leverage those and leverage them across several different things. Here on the far left, we know that health and equity is driven by racist policies and ideas. And we know that things like bias or implicit bias, explicit bias affects, distorts decisions, and creates structural inequities and inequalities. It also creates disproportionate impacts and obviously discrimination. So if we take the ability to use the 8 Ps in technology and we look at what we're attacking, structural inequity, we can begin to come across to where we want to be, which is health equity, driven by anti-racist policies and ideas. So as we continue to understand what we're up against and we continue to use these 8 Ps in technology effectively, we can get to the equity that we want. Here's another way to look at it. We believe that health equity is part of an intentional journey. It's an anti-racist journey. And it starts with awareness and understanding. And sometimes people get stuck there. All day long, people are having epiphanies about how they now understand and are aware, and they never get to the next level that they've got to continue to move on, and that is accountability, right? You have to take on accountability if you have understanding and awareness. And what do you do with your accountability? You move to advocacy and action. And we again say, use these 8 Ps and technology to leverage that. Advocacy and action, intentional to get to equity and to get to anti-racism, which is part of the work that we're doing. So this is another model that we use when we talk about what's this journey look like? Remember, walker, the road is made by walking. So then, if we know that health equity is about anti-racism and intersectionality, the dynamics that give us racism, we know that there are dynamics that give us anti-racism. If racism, and this is a definition that Professor Kendi uses, racism is the marriage of racist policies and racist ideas that produce and normalize and sustain racial inequity, we know that the opposite can be true to get to anti-racism. It's going to be the marriage of anti-racist policies, anti-racist ideas, that is going to get us to equity. It is your job in your organization to continue to root out the racist policies, the racist ideas and stereotypes and beliefs that your organization holds as a group and as individuals who make up the group, and get to anti-racist policies, anti-racist ideas. So what else do we know? We know that there's no such thing as a not racist idea. There's only racist ideas or anti-racist ideas. I'm going to take just a moment more with this. A lot of people go, I'm not racist. What a declaration that is. I'm not racist, therefore I'm good, right? I'm not contributing to racism. Professor Kendi tells us that, there is no such thing as not racist. There's racist, but there's also actively moving against racism. Thoughts, ideas, beliefs, actions against racism is how we get to anti-racism. We can't have people being neutral, sitting around going, I don't say the N-word. You know, I didn't own slaves. I don't do things that are bad and racist, so I'm good. No. You must be thinking about, what am I doing that's anti-racist? And here's a little permission that he gives us. We backslide at times, and we end up saying and doing and thinking and acting on racist stuff. We must look back to our awareness and understanding and accountability and say, I must move to doing anti-racist stuff. So yes, he understands that we make mistakes, but we don't get to say, I made a mistake, I'm going to hide in a corner. We must continue to be anti-racist. But here's another thing that we have to deal with. There are 2 simultaneous forces always at work, and we cannot be discouraged by them, but they're this. There's the progression of health inequity at all times, and there's the progress that we make in bringing more health equity and advancing it. But we also have the idea that even as we're making health equity progress, we're still encumbered by an upward progression of health inequity. So anybody who believes that this is chronological or the advancement is linear is just wrong. You are always competing with health equity and health inequity, just as we're always competing with racism and anti-racism, misogyny and whatever the opposite misogyny is. So as we keep this in mind, we know where our work is. It's to continue to uplift health equity progress. Let's talk for a moment about another philosophy that our group holds, and that's the inside-out theorem. We believe that the work in the organization to deliver the best programs, most responsive programs to our communities, is ultimately what we're all striving for. But what that means is that we've got to be aware that professionally, it's also personal, because we change as we do this work. And personally, as we change, we continue to change our professional work. So that is the inside-out theorem in a nutshell. And obviously, when we are doing it, when we are serious about it, then we are all winning, including the communities that we serve. Here's Professor Kendi again. He wants to remind us that health and racial inequity is a problem of bad policy, bad ideas, not people. Let's not get stuck on taking it personally. Let's get stuck on doing the good work that we must do. even as we build our awareness and our understanding, take on our accountability, and therefore get to advocacy and action for health equity and anti-racist policies and ideas. Well, we have to have capacity to do this, right? So this is the definition of capacity that we like to work with. And it's also juxtaposed against health equity, the state in which everyone has a fair and just opportunity to attain their highest level of health. Remember, the work is not, I'm in process to do the work. The ultimate goal is getting to that health equity. You saw this earlier when Bernadette spoke. Health equity's got to be all levels of the work that you're doing. So here's the CDC model. Individual, relationship, community, and societal, all of that health equity work is piercing through that. And look at the critical success factors. We can't ignore these. This is part of how we're going to get there. We've got to have success. What does it look like? Well, it looks like skill. And that's knowledge and competency. It looks like will. Do you know that we've worked with organizations that think they want to do this work, but in the end they don't? They have literally said, you know what? We're not ready to do this after all. Thank you and goodbye. Or they've said to us, we thought we were doing it. You guys keep telling us we got to do more, and we just don't think this relationship can work anymore. And that's okay, right? But what that means is there are a lot of organizations and people not ready to do the work. So will is you've got to be ready, because you've got to be successful. And then capacity is putting that all together: skill, knowledge, desire, passion, and oh yeah, let's hope you have enough money, you have the time, and you make it a priority. Oh, is it time for an activity? Toni, let me give it back to you. Thanks.
I'll admit. All right. So this is where you take the good work and that incredible discussion. I could just tell how much you guys were into that first activity. What we want you to do is to describe the actions you believe your organization is taking to infuse anti-racism and health equity into what they do. It's sort of a tall order, but keep it simple. What comes top of mind? And if you find that maybe it is not as much, maybe you have to say, where are the opportunities, right? Describe how you hold yourself accountable. How many of you have worked in organizations? You have a point of view. Maybe your organization may not be as much in that point of view, but you hold yourself accountable. So these two questions just seek for you to take what you were discussing a little earlier, a little bit deeper. What actions are your organizations taking to infuse? And then describe how you hold yourself accountable. 5 minutes pair share. You can go with the same people, or you can go with someone else. Thank you for, I just really can tell how much you are into these discussions, which tells you how passionate everybody is. What I would like to do, though, is to invite Bernadette up, and she's going to give you an example of one of the elements that she found.
Yeah, we have a lot of work to do, let's be honest. But this is just one example of the things that we're working towards in order to improve our use of data within our program to inform the communities that we're working with. And I'm really excited to talk about this because this is the first time we're sharing anything about this, and it's incomplete. We know it will be imperfect when it's done, but it's hopefully getting us in the right direction and something we can continue to improve upon over time. So as I mentioned earlier, the data source that we used to identify high-risk communities in New York State 10 years ago was the highest average number of reported forcible rapes over a 5-year period reported to law enforcement. So I don't have to tell you why that is problematic or why only using one data source is just incomplete, no matter what we do. So we have been working really hard to construct an RPE risk assessment data index on risk for sexual violence. So currently, it is 3 domains: individual level, relationship level, and community level. The data that we're using in the individual level domain, most of it comes from the census data, although not all of it. And we are really looking to identify communities that we know are at highest, or individual characteristics for people who are at highest risk for sexual violence, based on what we know from national data sources that we do have. Then our relationship level, these are just some examples. Not all of these will be included and may change over time. But the data sources that you're seeing in these other 2 columns, I'll also just say, largely come from the CDC Veto Violence website. I think they have like well over 200 data sources that they've identified are related to the risk for different forms of violence. So, yeah. Victimization, great question. We want to get to perpetration, but we're not there yet. Yeah. So thank you for that question. So yeah, right now what we have, what we're using from the CDC, identified list of risk factors and data sources. Right, we have to narrow it down to what we have available at the county level in New York State. So right now we have things like connection to school, family conflict, unemployment, and then we do have some data sources specifically related to sexual violence in there. So we have hospital data and some criminal justice data. So yeah, any other questions? Okay, thank you.
So thank you again for the robust discussion. You see an example of what New York is looking at, many other areas, not just data. So I encourage you to think about how can you rethink about how you're doing things, and think about the SEM model and looking at each of those levels and how you can affect it. Again, if there are 10 opportunities and challenges you face, health equity is not number 11. It is part of those 10. So with that, I'd like to bring up Nora for our next part of our presentation.
Thank you, Toni. Deep breath. I'm trying to run through this real quick, so I'm going to skip some slides here. And let's land here. Okay. So as I said in the beginning, what we're really talking about are 3 different things, and we're trying to bring them together in a little Venn diagram with a sweet spot in the middle where we do our work, right? And pulling these 3 approaches together, I think, is really exciting. My training is in cultural studies. I am a sociology professor, and so thinking about how to solve problems with a public health approach in a public health realm is just a place I like to live intellectually. And we put together this framework to think about how to do that in an anti-racist context. And so, starting with primary sexual assault prevention, y'all know what this is. I don't have to tell you. But it's identifying risk and protective factors for both perpetration and for victimization. And I'm loving all I'm hearing about perpetration and considering how we reduce risk there and increase protective factors there, because that is absolutely where we need to go. And then, now the CDC has been listening to us, and people are thinking about health equity and thinking about health equity. There's been some good work around that, around Black women's maternal health, kind of driving the language around health equity, and I love seeing it coming into the public health space, because that's where the work can happen. But really important to identify and engage communities inequitably impacted and individuals inequitably impacted by sexual violence, right? So yes, we look at risk and protective factors, but we need to look at the inequities that are driving them, right? So who is safer, who is at higher risk, and what are the individual characteristics like that? But here's the thing about the equity word, and I'm a DREI professional, right? So the reason we put the R in DREI is because if you don't talk about race, then people will just gloss over it. People don't want to talk about it. And you have to be specific. You have to be specific about anti-racism. And when I say anti-racism, I mean anti-racism in its most intersectional form in the tradition of Black women feminism, and of women of color feminism, and of international women feminism. That is what I am speaking of. I'm not speaking of white corporate women's feminism. And so when you talk about a process of anti-racism, and that's part of the reason we kind of latched on to Kendi's work, is because Kendi lays out a process, right, where you can identify, if you start with racial equity, and you identify where the inequity is, where is there a disproportionate impact in terms of race, or in terms of race and gender, or in terms of race and gender and sexuality, or race and gender and disability, find those intersecting inequities, and then look at what are the policies that are causing them? What are the policies that sustain them? Why did these inequities exist? They exist because somebody decided to do things a certain way. And it was a way that either erased, ignored, or deliberately chose to exclude a certain population. Women of color, trans folks, people who are disabled were erased from the space. And so you have to look specifically at that. And then when you say, well, why do these policies exist? Well, there's ideas that make it okay for these policies to exist. And those are the racist ideas that we're challenging, right? So where did I learn those ideas? Where did I learn that this was okay? And how can I unlearn it? And what's a better thing to learn instead? That's why it becomes an anti-racist effort. Right? And then you identify and challenge those racist ideas and create new ideas. You say, no, it is not okay to leave and exclude. It is not okay that Black women face such incredible disparities and outcomes when they're having babies compared to white women. That is just not okay. And you challenge that with anti-racist ideas. And then you develop policies to remedy. And so that's the anti-racist process, as Kendi describes it. We think it works real well when we're working about operationalizing things, because we go back to systems and we say, okay, where are these things showing up in systems? And so that's our anti-racist policy, our process. And then what that looks like when you put it in a public health context, you get this sense of doing this work where you're looking at, okay, what are the racial inequities of risk and protection factors? What are the policies that can increase risk and decrease risk, and increase protective factors? What are the ideas that are keeping us from implementing those policies, and how can we change them? And then what can we do differently and better? How can we change our ideas and develop new policies? And that's the sweet spot, in our opinion. And that's how we approach an operationalizing of these ideas. And Michelle's going to talk to you a little bit more about our findings in a second. But I just want to say that what that then looks like is doing, and this list, which I love, comes from a report that came out in 2021, which I hope many of you have seen, because it came from the Prevention Institute and the NSAC. But it talks about that primary prevention is elevating community leadership and resilience. Primary prevention is creating spaces for healing. But when you're being anti-racist about it, and you're working in that sweet spot, you're talking about elevating the leadership of communities, specific communities that are most impacted by sexual violence, right? You're talking about creating healing spaces. Someone asked me, what do you mean by creating healing spaces? Well, are those spaces anti-racist? Are those spaces trauma-informed? Are those spaces where when a survivor walks in, she's going to feel seen, they're going to feel known, they're going to be safe? Even if the work isn't necessarily addressing sexual violence overtly, even if it's a housing project, right? Which I love what Kansas is doing, expanding the idea of prevention. That's part of what we endorse also, is that prevention isn't just curriculum, it's so many other things, right? But in a housing space, in a youth advocacy space, you're still creating a healing space for sexual violence by creating a safety. And where everything I know about creating safety, I learned from people doing this work. So we are the ones to carry it forward. I'm going to stop right here. I think I've said enough, and I'm going to turn it over to Michelle to talk more about our process.
Thanks for that, Nora. And we are looking at time. I have a message of how much time we have left. Thank you for that, Jen. And I think that I am going to give this next part to Toni, because Toni doesn't talk as fast as I do, and you'll be able to get more out of it. Thanks, Toni.
So back to our methodology, we told you about the journey, and this is how we hold ourselves accountable and going and doing the work with whoever we happen to be doing the work with. This model of awareness, accountability, and the 8 Ps. Because we're working with New York and Bernadette and her paradigm, the 5 guiding principles in this arena we use from the CDC could be helpful for your organizations, or you might find in the arena you're in, whatever jurisdiction you're working in, there could be something that's valuable as well. But we use these 5 principles looking at internal capacity, data availability, training and technical assistance, partnership, distribution of programs across the SEM model. By our doing a deep dumpster dive into the data, into the information, meeting every week with Bernadette and going like, did we get it right? Do we understand it? That's how we could help her and her team understand. Because if you can't describe it, you can't manage it. If you can't manage it, you can't improve it. And if you can't improve it, you can't innovate it. So we used these guiding principles to help us help them. So our goal, again, was to understand how inequitable health and racist policies were operating in their organization, how they did the work, who they did the work with, what was even happening within their organization. And that's when we did the survey and the one-on-one interviews that I mentioned before. Our goal also from an awareness standpoint was to make sure common language, and we sort of spoke to that. Additionally, our goal in working with Bernadette and her team was to gain and validate and demonstrate that we did understand by doing that data review, by looking at the programs and the outcomes, talking to the people, and then having ongoing discussions with Bernadette and her team to make sure we were seeing and hearing it right. And then from an action and advocacy standpoint, using all that information, crafting recommendations. You got a list of findings. Now, what are you going to do about it? And I will add, what are you going to do about it? The list is going to be long. The list is going to be too long. You can't do it all. And if you remember, one of the 8 Ps is priority. It's the hardest thing for any person, family, organization, community, you name it, to do. And that is part of the secret sauce of our work with Bernadette. So I'm going to turn this over now to Michelle, I believe, to talk about the early considerations based on what we found. I'm going to turn it over to Nora.
So nobody wants me to talk fast? Okay.
I'll talk fast. It's my turn to talk fast again. Okay, so early considerations. As I said, we're not going to give you the long list, but some general themes that came up. Resources are real limited. I mean, you all know that new CDC grant is coming out is actually in real dollars less money than in the previous 2 funding cycles. And that's going to suck. That's the technical sociological term for it. It's going to suck. And so deciding where to go broad and where to go deep. And that sounds real general, but we've made we're thinking really hard about what that means, so that, people can be Well, I'll give you a little hint. We're suggesting kind of a two-tiered approach, right? That some services are statewide, and then a few programs are going deep. And that way there's resources that can be given to the whole state, and then a few that can go real deep and do the work and make an impact. And addressing capacity in that way. Addressing the scope and the nature of the effort. Then to improve the data approach, and that has been, a major piece of this was looking at how they use data, how they're collecting data. It has not been what it should be, and I really applaud the efforts of Bernadette and her team to expand the way they're using data. Thank you. That's perfect. Thank you. And then also rethinking and expanding the idea of partners. I mean, the Partners for Data Prevention have largely been, and this is my heart, it's where I started doing the work in rape crisis programs. But is crisis response really the space to think about prevention? And when you think about like what's going on in Kansas, where they're like partnering with housing programs, partnering with community groups, partnering with, I'm a youth worker, I love to see partnering with young people and training them to do the work. And yes, deliver curriculum, yes, talk about safety, but schools are not proving to good partners. And yes, we need to have strategies for re-engaging schools and getting past that, but we can also deliver curriculum in other places. So think about, how can we expand who our partners are at the community level, and really doubling down really hard on what we mean by community engagement, and infusing, community participation at the assessment level, at the program planning and developing, at the evaluation level afterwards. At every turn, there should be this relationship going on where we are bringers of resource, but the expertise and the actual stakes of who's impacted are the community. And really operationalizing that across our programs is what we recommend. Again, that's why I said thinking about primary prevention beyond curriculum, thinking about how to improve staff capacity. And so this is a thing where this is the inside out thing, and this goes back to good old basic DREI and good old basic HR. There is a relationship that employees have with their agencies, and at every point in the relationship is an opportunity to introduce anti-racist ideas and anti-racist policies. One of those is competency-based hiring. So every organization, and I will just want to make the case, if you're not doing it, your job descriptions should not be vague. They should be specific. And they shouldn't be based on necessarily experience, but the ability to demonstrate competency. And we call those, one way HR folks talk about competencies is knowledge, skills, and abilities. And the more specific you can be about the knowledge and skills and abilities that a job requires, then the more specific you can be about screening for that, about evaluating performance based on that, and about supporting growth for your staff in those areas, but through training. You can't train ourselves into anti-racism alone, but there is an element of training, and when that training is competency-based, based on building up people's skills to do the work and defining what those skills are, the specific skills needed to do this work from an anti-racist, health equity, primary prevention place is where you need to be. Yeah, I think that's all I need to say on that. Happy to talk to anyone about it. We've made it into our final workshop, our final activity. And that is going to be, Toni, are you going to describe the final activity? Okay.
So you guys have been doing a lot of thinking. Hopefully we've given you some pause for thought. I love the discussions you're having between one another. Now, we'd like you to use your workbooks and take one of those challenges and list ways to address them. And just going to give you a couple of minutes because we'd like you to share that with other folks. We'd like to have a share out. Anyone who would like to, we will run a mic to you. So if you could do that, spend a couple of minutes. List ways to address one of the challenges that you found related to the work with health equity. Okay, we're not going to give the full 10 minutes because I know we're running out of time. Who would like to share what their challenge was and some actions that they're going to take? Anybody like to share out? Wow, you got bashful all of a sudden.
So I work with Bernadette. I'm at the New York State Office for the Prevention of Domestic Violence. And I didn't know we were doing this. So I'm really excited. I want to talk to all of you. My solution is I'm going to talk to Bernadette and all of you and our state coalition partners to figure out what's the common languages at least we should be using and how do we implement that within policy across the 6 state agencies that deal with these issues.
I'm piggybacking on Kelly because, like, when I came up with one of my challenges, I was like, oh, I need to just actually be explicit and say, hey, state agencies and coalition partners, let's work together. As someone who's been in sexual assault and racial equity, so understands both sets of challenges from a public health and a humanities lens. There are good programs that are exemplified in like lots of different countries. So let's partner.
We were having a conversation about sometimes health equity might seem racist because we might target specific populations because they're in disadvantage, but that's not the idea. The idea is to make sure we lift them all. We had the conversation of everybody's in first grade, but some kids might learn faster to read than others, so we gotta support those that can't read. And yeah, that might look like we're pushing those because we see them in disadvantage, but we want to make sure everybody gets the same treatment, but provide extra support on that. So I think for us in the County of Los Angeles, we're working with providers that give the service to our different communities. We're a very vast population and very different ethnic backgrounds. So make sure that everybody gets standard procedures on how to do things, but also those who have different ethnic backgrounds that they need to serve get the extra support to communicate with those communities.
I love these comments. And again, looking back at the model that we use, the P of priority is not necessarily an inequitable thing. You do have to choose. I would believe that what is inequitable, if you go too broad and try and do too much, then it doesn't help anybody, right? So you have to choose, you have to be specific, you have to describe the success, because that's what's going to happen. When you prioritize, when you think through the P's, is it a policy, is it a procedure, whatever it is, then you have success. You describe the success, you look back to your funder and say, I had some success. Higher probability that you could get some money, no promises, but you could get some more money. Or you get creative and there's a grant out there and they go like, they can describe what they did, how they did it, and what the result was. And that's where you need to be. All right. I think I'm going to, oh, yes.
Okay, not a solution, but a quick question. I think listening about the issue of priority especially, how do you navigate that when you have maybe people in a hierarchy or higher than you who are resistant to just looking at is their priority or making a big deal of that's going to be a problem and still do the work?
I know my strengths. I'm handing it off.
I'll take that. Yeah, I mean, that's hard. Sometimes, I mean, if you can find allies and go above them and work it that way, sometimes you just got to find your anti-racist power and advocate upwards, upstream, and speak your truth and say, listen, this is what it is. These people are impacted unfairly. This is, and just be very clear of, you know, bring the data, bring the results, describe very clearly the inequity that you're trying to address, describe the reason that policy is unfair and the policies that support it, and say these policies need to change because it's creating this inequity. And there's ideas behind that make us think that is okay, and it's not. And sometimes you just got to stand in your truth and find your power. And I hope for that. Yes.
And if I could just add to that too, you know, I think we've worked really hard together to think about where we do have influence, because, you know, being at a state agency, there's so many things that are union requirements, civil service requirements that we just do not have control over. And so I'm never going to be able to change those policies. So really just like, what can I do now? And thinking about, well, the thing that I do create is the job description, for example. So just like trying to find the little areas where I do have influence.
Thank you. Absolutely. I think Michelle has one more thing and we're done.
Thank you, everyone. We are just about done. I want to thank you again for coming. I want to thank you for engaging with each other. Again, talking to people that you may not have known because you've got common ideas and common solutions bubbling up. So thank you so much for that. We hope that you'll use the workbook, something you can take away and reflect on and continue to think about where can I make my change individual and operational. The last thing I want to do, though, is we are using, again, the language of Antonio Machado, the Spanish poet, to remind ourselves that we are building that road one step at a time. And as others come along the path with us, we're all building it together. Angela, would you mind doing the first part of that poem in Spanish? That would be so beautiful for us if you could. Thank you.
Of course, since I know it by heart since I was 12 years old. Antonio Machado, caminante no hay camino, se hace camino al andar. Al andar se hace camino y al volver la vista atrás se ve el sendero que nunca más se ha de volver a cruzar. Caminante, no hay caminos sino estelas en la mar.
Oh, thank you. Thank you so much. Well, everyone, we will stay for a few minutes. If you have questions, want to ask us anything, we have our contact information in the workbook, and we're happy to talk to you some more about what we've offered New York and what New York has worked with us on. Thank you.